This split-screen chart illustrates a glaring discrepancy in how we track attention deficit hyperactivity disorder. In childhood, prevalence sits at roughly 5.5%, but among adults, official diagnoses drop to just 2.5%. For decades, the medical community connected these 2 points with a descending line, assuming the disorder simply burned out by age 30. Genomic data tells a different story. The underlying genetic architecture of the disorder remains remarkably stable as a patient ages. Genome-wide association studies tracking 27 specific loci show a genetic correlation of greater than 0.8. This indicates that the childhood and adult presentations of the disorder share a nearly identical genetic background. If the underlying biology is consistent across the lifespan, we have to ask why so many adults fail to meet the standard diagnostic criteria laid out in the DSM-5. This discrepancy creates systemic underdiagnosis. By relying on pediatric behavioral models, clinicians routinely miss mature expressions of the disorder, leaving millions without medical support. This clinical blind spot falls heavily on specific demographics, most notably adult women and individuals with high intelligence test scores. The condition undergoes heterotypic continuity. The genotype remains constant, but the observable phenotype evolves as the brain matures. Heterotypic continuity occurs when a stable genetic trait produces different symptoms as the brain undergoes neurodevelopment. The cause remains static, the output shifts. We can observe this evolution on a clinical timeline. The classic pediatric presentation is defined by motor hyperactivity. As the brain matures, that physical hyperactivity internalizes, manifesting in adults as chronic inner restlessness, an inability to relax, and severe emotional dysregulation. Pediatric inattention also mutates into complex executive dysfunction. The mature brain struggles to organize long-term planning, sequence tasks, or regulate immediate emotional responses. Crucially, severe executive dysfunction and emotional dysregulation are not currently listed as core symptoms in standard diagnostic manuals. This creates friction in the clinic. A patient presents with debilitating impairment in their daily life, yet they fail the diagnostic checklist because that list was calibrated for a 7-year-old. Relying on pediatric behavioral criteria to diagnose mature adults misrepresents the pathology and blocks access to targeted medical treatment. This brings us to the controversial clinical phenomenon of late-onset ADHD. The data shows that over 90% of apparent adult-onset cases are ruled out when researchers apply rigorous developmental timelines and examine childhood histories. This graph maps the mechanism. We plot lifespan against executive load. A blue line represents internal capacity, staying safely above the red line of environmental demand during childhood. At the career stage, demand spikes violently upward, crossing their capacity. This intersection marks the exact moment of clinical impairment. It is not the onset of a new disease. The clinical error lies in the baseline for comparison. Clinicians often measure impairment against the general population, rather than measuring it against the high IQ individual's actual cognitive potential. A patient might meet average societal benchmarks, holding down a job and paying bills, but failing to reach their own internal aptitude generates intense psychological distress and burnout. Evidence suggests that late-onset cases represent the delayed collapse of compensatory masking once environmental demands finally exceed a patient's capacity. This masking effect is heavily tied to sex. In childhood, males are diagnosed at 3 times the rate of females. By adulthood, that ratio closes to nearly 1-to-1. Females frequently utilize passive social camouflage to hide their symptoms. Their presentation skews toward inattention, rather than the disruptive behaviors that trigger early clinical referrals. By the time they reach adulthood, up to 80% of these patients present with at least one comorbid psychiatric condition. This Venn diagram maps the primary overlaps. The core neurodevelopmental disorder is flanked by internalizing conditions like anxiety and depression, or externalizing issues like substance use. This triggers diagnostic overshadowing, where a clinician identifies the secondary condition and stops investigating. Overshadowing disproportionately impacts women. Their internalized symptoms lead practitioners to diagnose a primary anxiety or depressive disorder, missing the root cause. Treating the resulting anxiety without addressing the underlying attention deficit leaves the neurodevelopmental engine driving that anxiety completely intact. The patient remains trapped in a cycle of failed interventions. Diagnostic overshadowing punishes patients whose symptoms internalize rather than disrupt the classroom, turning their condition into a systemic clinical blind spot. Moving past the diagnostic hurdles requires understanding the pharmacological realities of treating the adult brain. This schematic details primary stimulants like methylphenidate. In the prefrontal cortex, these molecules inhibit dopamine and noradrenaline transporters, physically blocking reuptake. This elevates neurotransmitter levels in the synaptic cleft, providing chemical stabilization to networks responsible for executive function. Clinicians often hesitate to prescribe these stimulants to patients with comorbid substance use disorders, fearing an exacerbation of addiction. Yet the clinical data points the opposite direction. When carefully monitored, long-acting stimulants reduce substance abuse, unintentional injuries, and all-cause mortality in this population. Untreated symptoms also carry highly significant risks for overall physical health, with recent data revealing severe somatic complications. This data table, drawn from Swedish health registries, highlights the specific physical toll. Adults with the disorder face elevated odds ratios for sleep disorders at 4.6, asthma at 2.4, and a hazard ratio of 2.1 for cardiovascular disease. These associations include an increased risk for 13 distinct autoimmune diseases and a vulnerability to cardiac arrest and hemorrhagic stroke. Despite the severity of these adult complications, institutional research funding remains disproportionately allocated to pediatric studies. Adult ADHD represents a systemic, body-wide health risk that requires aggressive, comprehensive medical management. The data demands a new diagnostic mandate. Clinicians must actively look past pediatric checklists when evaluating mature patients. Accurate assessment requires evaluating lifelong developmental timelines, executive burnout, and emotional dysregulation, rather than searching for childhood hyperactivity. While pharmacology is highly efficacious for stabilizing core neurochemical symptoms, a pill alone is insufficient for total functional recovery. Medical intervention must be paired with specialized cognitive behavioral therapy, designed to dismantle the internalized negative cognitive triad built up over years of untreated struggle. Effective lifespan care integrates the neurodiversity framework with existing clinical models. We must combine symptom suppression with environmental matching and skills coaching. The core tenet here is that impairment often stems from a mismatch between a neurodivergent brain and a rigid neurotypical environment. The ultimate goal of clinical intervention is not simply to suppress a list of symptoms. It is to permanently align a patient's external environment with their unique, mature cognitive architecture.